Hi dear friends, welcome back to my channel. I have started a new series on nephrocritical care where I will be speaking on various topics related to acute kidney injury and renal replacement therapy. Acute kidney injury is a syndrome characterized by a rapid worsening of kidney functions. Rapid worsening of renal functions is associated with serious short and long-term complications such as hyperkalemia, respiratory distress, various kinds of cardiac arrhythmias, and over a period of time, AKI may progress to chronic kidney disease. Therefore, AKI is now recognized as a major public health problem. Rapid diagnosis and appropriate diagnostic workup are essential elements of management to identify the types of AKI where specific therapies and interventions may reverse the progression of AKI. In this video, I am going to discuss in detail how we can best diagnose AKI. The diagnosis of AKI is traditionally based on a rise in serum creatinine and or a fall in urine output, that is oliguria. There are more than 30 definitions of AKI which have been published in the literature. However, definitions and staging proposed by Rifle, Acute and Kedigo are the important ones that we should know and discuss. Rifle classification was proposed in 2004, which defines three grades of severity: risk, injury and failure, and two classes of outcome: loss and end-stage kidney disease. Rifle classification had many inherent shortcomings like the requirement of true GFR rather than an estimated GFR, and baseline creatinine was also required to estimate the degree of kidney injury. Another shortcoming was the hydration status was not factored into the definition given by Rifle criteria. That is the reason in 2007 Acute criteria were proposed, which was a modified version of Rifle in which the true GFR was replaced by an estimated GFR, which was acceptable, and baseline creatinine was not needed and it was replaced by two creatinine measurements taken in 48-hour time frame. Another main advantage of Acute over Rifle was that definition was applied after an adequate hydration status was achieved. Though Acute was tested to be more sensitive than Rifle criteria, it could not show a greater prognostic value. Therefore, in 2012, both Rifle and Acute criteria were merged, resulting in Kedigo classification, which has emerged as a unified system to maintain the international coherence of research. So we follow nowadays the Kedigo criteria. At the present time, AKI is diagnosed if serum creatinine increases by 0.3 mg per deciliter or more in a 48-hour time frame, or increase in serum creatinine, or if serum creatinine increases to at least 1.5 fold from baseline within 7 days, or urine output less than 0.5 ml per kg per hour for more than 6 hours. Both changes in creatinine and urine output are important to stage the AKI because a recent study in more than 32,000 critically ill patients found that the prediction was better if we took both the criteria of AKI, creatinine as well as the urine output. However, serum creatinine and urine output are the markers of excretory functions of kidney only and do not provide any information about other roles of kidney such as the metabolic, endocrine and immunological functions of kidney. Now we will discuss main limitations of using both creatinine and urine output as traditional diagnostic criteria of AKI. Let's understand the limitations of creatinine based criteria first. Number one limitation is that the creatinine concentration is influenced by many factors, like by the amount of creatine ingested and synthesized in pancreas and liver, and also it depends on the muscle function and muscle mass of the body. Number two limitation is that the relationship of creatinine to GFR is not linear. A true fall in GFR may not be adequately reflected by the serum creatinine in patients with sepsis, liver disease and or muscle wasting. Number three limitation is that it is a delayed marker of kidney injury because of the prolongation of half-life of it by the drop in GFR, because its concentration may take 24 to 36 hours after a certain renal insult. Remember that by the time the creatinine has increased above the upper limit of the normal laboratory range, half of the GFR or renal function will be lost. Number 4 limitation is that its estimation is not reliable. There is no standardized laboratory method for quantifying serum creatinine, and substances like bilirubin or even a few drugs may interfere with certain analytical techniques, more commonly with the Jaffe-based techniques. Number 5 limitation is that creatinine value is affected by variations in the volume status, which is quite changing in the critically ill patient. Therefore, in volume overload after fluid resuscitation in shock, diagnosis of AKI may be delayed or even missed. Number 6 limitation is that it does not take into account underlying renal reserve, that's whether it is normal or declining. For example, a rise in serum creatinine by 0.3 mg per deciliter in a patient with normal kidney function reflects a major reduction in GFR. In contrast, the same rise in serum creatinine by 0.3 mg per deciliter in a CKD patient where the renal reserve is already low may seem to reflect a minor change in GFR. Another limitation that I would like to highlight is that the creatinine criteria do not provide any information about whether kidney injury is progressive or recovery. So it fails to provide any prognostic information. Now we will discuss the limitations of urine output criteria separately. The first limitation is that the urine output is not a specific criterion to detect AKI patients. In fact, urine output may persist until renal function almost ceases. Oliguria may be an appropriate physiological response of functioning kidneys during the periods of prolonged fasting, hypovolemia, post-surgery, or following the stress, pain, and trauma. So there are various factors which can decrease the urine output due to increase in the ADH hormone, that is antidiuretic hormone, in times of stress, pain, surgery, trauma, etc. Similarly, good urine output may exist despite a decline in GFR. Severe AKI can exist with the normal or increased urine output, and sometimes you give the diuretics. So in those cases, urine output is not a reliable criteria to detect the AKI or to diagnose the AKI. Another limitation is that the arbitrary cutoff of 6 hours duration in guidelines, which has been described in staging the renal dysfunction. Experts suggest longer is the duration, higher will be the specificity of the urine output criteria. So we must wait for urine output criteria to define the AKI. Now, having known the limitations of creatinine and urine output both as a criteria of diagnosis of AKI, there are various other biomarkers proposed to fill the deficiency of these two criteria, these two traditional criteria, such as the biomarkers. This is particularly relevant for critically ill patients where the presence of fluid overload, muscle wasting, sepsis, liver disease, reduced effective circulatory volume may completely mask the diagnosis of AKI. There has been a battery of serum and urinary biomarkers of AKI which have been discovered, researched, and validated in recent past. Biomarkers for AKI can be stratified into the markers which primarily reflect the glomerular filtration, like the serum cystatin C. Some markers reflect glomerular integrity, like albumin and protein in urine. Another set of biomarkers predict the tubular stress, for example IGF-BP7 and TIMP2. Biomarkers of tubular damage are NGAL, KIM1 and LFAB. Few of them are predictive of intrarenal inflammation like IL-18. These biomarkers can provide a plethora of information regarding the underlying etiology and indicate different stages of the pathophysiological processes involved in AKI from injury to recovery. These biomarkers are so sensitive that they can detect a subclinical AKI which is characterized by biomarker positive and normal creatinine. So that's subclinical AKI. Studies have shown that such patients appear to have greater risk of complications, a longer stay in the hospital, and higher mortality compared to patients without a biomarker rise. Recognizing their crucial role in critical care nephrology, 10th Acute Dialysis Quality Initiative Consensus Conference proposed to utilize both functional and damage biomarkers in combination with the traditional markers of acute kidney injury to define and characterize and stage the AKI. Commercial kits for the measurements of cystatin C and GAL, IFBP7 and TIMP2 are available nowadays. Having talked about the early detection of AKI using traditional and novel biomarkers, let's move on to discuss the next part of my video, which is acute kidney disease or AKD. So far we have learned AKI, right, which occurs over 7 days period. You may also be aware of the CKD definition, which starts when kidney disease has persisted for more than 90 days or 3 months. Now to fill this continuum of kidney damage, the KDIGO expert group proposed the term acute kidney disease or AKD. So AKD patients are those AKI patients who continue to have renal dysfunction beyond a week but resolve before 3 months. So we have discussed the important limitations of various diagnostic criteria and important staging systems, and we know that we are still using KDIGO, which is in near future going to be updated and including the novel biomarkers. Now only issue is the cost of biomarkers, which will come down in with the widespread use hopefully. So thank you so much for your attention. Subscribe to my channel if you have not, and share this video with the maximum number of people who are genuinely interested in critically ill patient and critical care medicine, because this is a life-saving specialty.